Hello guys. So in today's video we are going to talk about cord prolapse. So when I say cord prolapse, that means umbilical cord prolapse. Now the definition is abnormal descent of the umbilical cord by the side of the presenting part. Okay, so when the umbilical cord comes out along with or the before the baby's presenting part, which may be head, which may be bridge, which may be anything, so that's called cord prolapse. Now, it can be three types: occult prolapse, overt prolapse, or only cord presentation. So, in which occult prolapse, that means we cannot see that, we cannot diagnose this, or we cannot identify the cord prolapse even if it is occurring. For example, if it is a presenting part of the baby here, okay, here I have seen as a as a ball or a head, but it can be breech as well. So when it comes out of the cervix, the cord is just alongside the presenting part. It is not seen outside, so we cannot feel it, we cannot see it. So that is called occult prolapse. Now overt prolapse means we can definitely see the cord coming outside of the cervix or even sometimes outside of the vagina, which is frank prolapse. Now cord presentation means the members are still intact. When we try to feel, when we do the vaginal examination, we try to feel the presenting part, we feel cord instead of the presenting part, which may be either bridge, which may be either head. So that is called cord presentation. Now this occult prolapse can only be seen by the ultrasound, that okay, the cord is there nearby the presenting part. Now the incidence, this is very important. Incidence is according to one of the very good RCOG paper, it is 0.1 to 0.6% of the births. Okay, it is increased into breech presentation. We have data on the breech presentation only, and that is 1%. Now, what are the risk factors for the cord prolapse? That means that when you see a patient in your antenatal clinic, you must be having such kind of things in your mind that okay, this patient can have cord prolapse at the end of the day. And when you do a delivery, when the patient comes into the labor, you must make arrangements for this patient, that this patient should not have a delivery at home, or it should be in the hospital where the Cesarean section is readily available. So now prematurity and congenital malformation are the most prominent association with the cord prolapse, right? So when the baby is premature, less than 37 weeks, or the baby is having congenital malformation, the risk of cord prolapse is high. Now the other risk factor as a list, I can say multiparity. When the lady is a grand multipara, there is a chance of cord prolapse. Low birth weight, less than 2.5 kg or 2500 grams. Preterm baby, less than 37 weeks. Baby with a congenital malformation, of course. Breech presentation, transverse lie, oblique lie, unstable lie. Now, what is unstable lie? Unstable lie means the baby's vertical presentation keeps changing even after 36 weeks. So we think that in the primigravida at 36 weeks and the multigravida at 37 weeks, the baby's presentation should be fixed. Even in the multipara, it is not even fixed at 37 weeks, but we take 37 as a guess mark. But for primigravida, yes, at the 36 weeks, if the baby is well good, it's the baby have the good weight, it should be fixed by 36 weeks. So if it keeps changing, then we know that it's an unstable lie and it's a risk factor for the cord prolapse. Now, when the second twin is delivered vaginally, that means the first twin has been delivered already and the second twin is being delivered. That time also the risk of cord prolapse is so high. So you have to be very cautious when you go for the delivery of the twins baby or even multiple babies. Now polyhydramnios is also a risk factor because it goes a kind nice space for the cord to roam around, and it can also it results into cord prolapse. Unengaged presenting part, which is obviously the unstable lie. Low lying placenta is also one of the risk because the cord is there only, at the lower part of the uterus. It just takes a little effort for the cord to come out. Now, Diagnosis, how we diagnose cord prolapse. Can you predict the cord prolapse? No, you cannot predict the cord prolapse. There have been studies, they say that they try to do it. They try to do the weekly ultrasound scans after 36 weeks of the patient just to assume or just to predict the cord prolapse. But it is not useful method because cord can come out of anywhere. You can't just predict it. But yes, in some cases where the bridge presentation, let's say if the bridge presentation the lady want to go for vaginal delivery, and after 36 weeks someone can suggest an ultrasound weekly to just see the cord presentation to predict cord prolapse. Yes, this has been done, but ultrasound per se is not very sensitive or even a predictor for the cord prolapse. Now, in those cases, definitely, what we should do, we should avoid membrane rupture. We'll go for the management in some time. Now, treatment is what is definitely the cesarean section in the most cases. When I say most cases, then which are the cases when we prefer vaginal delivery? Vaginal delivery is only allowed if it is very imminent. That means the patient is in full dilatation, the head is almost at +1 +2 station, then only you can go for vaginal delivery. Or even if the vaginal delivery is there, we try to do it rapidly by means of operative delivery, by means of using ventouse or forceps, but we try to make it quickly. So the thumb rule here is once we diagnose the cord prolapse, we must deliver the baby as soon as possible. Okay, now when you see a cord presentation while the patient is when having in labor, unexpected obviously, so we have to go for theater. First of all, we have to make arrangements for the theater. We have to go into the theater, keeping the all things for the cesarean section ready on time, and then we can deliver the baby if it is very proeminent to have a vaginal delivery. Now there is algorithm which says, it is very important. So say once you identify the cord prolapse, then first of all you have to inform your team, your specialist team, that is consultants, theater team, neonatologists. Primary measures which are not which are not very useful, but still we try to do it, is oxygen and hydration, bladder filling, which makes your presenting part little go upwards so that cord compression cannot happen. So cord compression is very important here, because sometimes if the presenting part is so applied over the cervix, it can compress the cord, and that's why the blood supply to the baby can be hampered. Now we need to do a bladder filling here, knee chest position, or even the modified Trendelenburg position. That is also important, so that the presenting part is not so firmly applied to the cervix, and that's why avoiding cord compression. Shift to the theater. Do not handle the cord, which is very important. Do not try to reduce the cord inside the uterus back, okay, because handling the cord can cause vasoconstriction of the umbilical vessels, which is obviously not good. Now once the baby is delivered, you have to do the cord blood sampling. You have to do the double sampling to make that, to make the impact, to see the impact of the cord prolapse. Now early cord clamping, let's say when the baby is delivered, should you do early cord clamping? Well, it is not associated with anything. If the baby is good, you can obviously go for delayed cord clamping. If the baby is not good, then obviously I have to do the early cord clamping and send baby for the resuscitation. So this is all about the cord prolapse. It's a very important complication of the labor, and you have to be very vigilant for this thing. How to be vigilant for that? For that you need to do routine fetal heart auscultation or continuous electrogram, ECG. Once you do the ARM, that is artificial rupture of membrane, or even after the spontaneous rupture of membrane. So you have to be very vigilant. If you see on the CTG, the variable deceleration are the findings of the cord prolapse, because it compresses the cord intermittently. So this is all about the cord prolapse. Thank you guys.